Hello everybody, my name is Tangella. I am a pathologist. I have a busy practice right across in the hospital there. So here's an opportunity for you to customize this lecture the way you want it to, and you're getting 1 hour of pathologist time, and you always wanted to ask the pathologist a question. This is the time to ask. Okay. The idea of my lecture today was to give the students, like I've done before, a little brief background of what pathology, the field of pathology is, and how biomedical research can help folks like you, are predominantly engineers, integrate into medical field. And there's a tremendous need for engineering and tremendous need for smart people like you to come up with innovative solutions for healthcare. So my idea was to just talk about one aspect of pathology, which was talk about peripheral blood, and just give you a component of, give you a little bit of idea of what is there red cells in the blood, which are kind of fascinating, and talk about them for a little bit. Talk to you a little bit about tissue pathology, how do we make diagnosis. If we find time, I think there could potentially be a tour of a histology lab where all the diagnoses get made in the hospital. Dr. Popescu and Marina is working on it, so hopefully there will be some time for a quick tour. So that's the idea. Do you have any questions that you ever wanted to ask a pathologist, and then get it out of the way now?
Nothing?
Nothing?
Okay.
Okay.
Aren't you worried your field is going to be taken over by computers?
Am I worried that how do you think it's going to happen?
Diagnostics, teach them how to look at samples and be very accurate in analyzing what they're seeing.
You have an idea for that?
You know how to do
You know how to do that?
Well, at some points, yeah, for some measurements already.
So you're
basically saying pattern recognition?
That, yes.
So you
So
teach
you
a computer
how to recognize certain patterns.
To recognize the pattern, to even test the mechanical properties, see whether the cells can be migrating or not, one of those.
Yeah.
Yeah.
Is it going to happen
in the next 25 years?
20 years?
20 years?
You're hoping.
Huh?
You're hoping.
I hope not.
I hope not, because that's when I'm going to retire. So your point is very well taken. So tissue analysis, rapid image analysis, followed by biochemical and physical properties integration. If you're able to put them all together, you probably will be able to make a very rapid diagnosis. Yes, that's absolutely possible. But right now, we are using rapid image analysis frequently in the lab, especially for urine analysis, where we have a database of images that we match up with what we are seeing under the microscope, and the program is called IRIS, and there are many programs like that. Instead of the technologist looking at the urine specimen for CAS, it's able to do it automatically, and the computer system is able to say this is all the stuff that's there in this urine. Similarly, image analysis is you can say image analysis is used for pap smears. 70% of pap smears in the country, in the United States, are not looked at by a human being anymore. It's all done by computer analysis. So those are the baby steps, if you want to call it, in tissue diagnosis that's occurring right now. I'm not worried about image analysis. I'm more afraid about genetic testing, molecular testing. With the rapid sequencing that's coming along, right now if somebody has a breast mass, you take a little piece of breast and then do an image analysis, which the pathologist comes in and takes a look at it and say it's cancer or not a cancer, and uses some kind of immunohistochemical stains or some kind of little bit of molecular methods to come up with a diagnosis. Well, now there are some molecular methods where they can do a gene profiling we can get up to 5,000, 10,000 genes of the breast cancer, and that can tell you the diagnosis, whether it's cancer or not. It can tell you prognosis, how bad the cancer is. It can give you predictive markers, which basically means what chemotherapy agents to use, what chemotherapy agents not to use, and certain molecular profiles actually help us predict how long the patient is going to live. So that's happening in molecular medicine right now. So we are in this renaissance of information growth, and you're absolutely correct. Image analysis will absolutely be part of what Dr. Popescu is doing. He's actually looking at refractive index of tissue and coming up with a certain patterns and certain information and matching it up with image analysis. And if we are able to get some Raman data to match up with that and get a little bit of proteomics, what's happening in the tissue, chemistry data. Now you have physical, chemical, image, structural, all this analysis, and yes, it's possible that a pathologist will be completely irrelevant. Dr. Popescu asked me, why do you want to do this research, because it's going to eliminate your job, right? I told Dr. Popescu when I collaborate with him, and I told him back then there are about 15,000 pathologists, okay, who are practicing in the country right now in the United States. I said, if I'm the one coming up with this technology, why the hell should I care about the other 14,999? I have a job, right? So I'll have a patent hopefully, and it'll be fine. So they are right. So that is. Any other questions? Yes.
All this comes when we know that there is cancer, like imaging. Is there any way to detect it before this, like in body fluid?
Yeah. So here's the question. I can guarantee you in the next 100 years you're going to die. Okay? I'll tell you, hold on, let me go what I'm trying to say. So would you like to know how, when, how painful is the death going to be? You do want to know. I don't think 99% of the people will like to know that. Similarly, we all know that we have hundreds and hundreds of cancer cells that are being made every day in the body. Every day. And our body has a natural immune response through what they call natural killer cells that kind of eat away and kind of destroy that. Turmeric, for example, right? That is an anti-cancer property and prevents colon cancer. It has been shown. So you will have data. Every day you get up in the morning, you get your profile, they'll say 50,000 cells have turned cancer today. What's your name? Rekha. Rekha has 50,000 cancer cells this morning, How would you like to start the day? Yeah. If you drink coffee, it says, oh, it became 2 cancer cells came up because of the caffeine. And you smell milk and it becomes, what I'm saying is it's a never ending information. The question is,
what's the point when we are studying it's already a cancer? But what's the point to tell me after getting a cancer that you can survive for 5 years?
Correct.
So you want more preventative information.
I want whatever I read about the biology. There are markers in blood, whatever is happening in the body.
Correct.
So is there any way when it is in the benign state,
Yes.
I can predict taking the
Right now we don't. That after the Human Genome Project was performed, where we know every sequence known to mankind, now we are doing what they call data mining. We're trying to understand genes. We are trying to understand, 97% of the human genome is absolutely gibberish. They don't stand for any proteins or genes or anything like that. It's just fillers. But now but the others, actually the 3% of the genome actually codes for something, a protein that's useful. But now we are realizing that this gibberish information is not just gibberish, because this is actually a spacer that keeps the 2 genes that are functioning either from each other. Like it's TNT, right? if you bring T, N, and T together, it's going to be explosion. Somehow the T is kept separately, N is kept separately, and T is kept separately, and then making them from coming together. In your situation, what you're asking is, you have seen Minority Report, the movie? Okay? So it'll be like, it's a Tom Cruise movie. You like Tom Cruise, Rekha? Okay. So it's like this, you go and arrest people based upon the future crimes they have not yet committed, right? So that's what you're asking, is like, tell me about the future cancers that have not occurred yet, and then take care of Rekha. So it will be really nice if I just take you right now. Let's go for a breast cancer surgery because 7 years from now you're going to have breast cancer.
No, that's what I don't want. I don't want to go for any surgery or any biopsy. I want some sort of connection body.
So you want to
turn completely into a mechanical robot where you don't have any biological system, which nothing can go wrong. Well, she's making a very good point. I'm harassing her right now. So the answer is, it is coming. But the discrimination, we talk about discrimination based upon the language, creed, color, race, geography, and all that we are known to mankind. It's going to be, I'm going to assure you, in 100 years from now, as the world gets more and more homogeneous, the discrimination will be genetic discrimination. And it will be based upon your gene profiles. In fact, what is that, 23andMe? Is that the company? You have heard of that, 23andMe? That's the company you're talking about, where they look at your genome and it will give you what genes you have that will increase your chances of cancer in future. That's what you're asking for right now. You can get it done, $300. How many would like you to know that what kind of cancers you are probably prone to in future today for $300? You would want to know? How many would you, huh?
It was like $99.
It's $99? Oh, you have a gift cert coupon, right? Oh, you've seen a ad? You have a coupon, so $99, okay? You would like to know that?
For 99, so you're I wouldn't want to know. I don't want to know, because I know I'm going to die.
Yeah, but you might increase your chances. I mean, if you know that you're going to, if you have a high possibility of having, I don't know, testicular cancer,
Right.
10 years, maybe you can.
What do I do? I check my balls every day in the morning when I'm like showering.
Just
I
an
mean,
example.
I don't want to live my life in fear, man.
Yeah, but that's why.
That's why cut it off. Your brain tumor decapitate? I mean, what are you talking about? There has to be. You think it's an easy answer, but it happens to you, it becomes scary. Look at what happened to, Angelina Jolie, right? Was it the right thing for her to get a double mastectomy?
As far as publicity, yeah.
For BRCA1 and BRCA2? It was a wrong publicity. I, as a man of science, I'll tell you, what she did was wrong.
Well, that's not fair. I mean, it was.
That's why I get paid.
It was
Say that.
It was her decision. So like maybe it was right for her, but maybe it'd be wrong for you. So
What
you
I'm
can't
saying
really
is,
say that for
what I'm saying
certificate.
She might have done it right, but she's a person of public status who can sway a lot of minds. If she thought it was her personal decision, she should have absolutely shut her mouth, done it, and not told the world about it, and freaked everybody out. I agree with what you said. Personal decision is a personal decision, but she is a public figure. At that point, when she goes and openly talks about it to everybody, correct? She's not keeping it personal anymore. That's my problem. I have no problem if somebody goes and whacks out their ovaries and say, I don't want any more children. No problem at all. But if they go and somebody like somebody we care about, somebody we look forward to as a public figure, and goes and says, I'm going to take my ovaries out because I don't want to have any more children in my life, okay? There are people who are not as intelligent who would sway for it and fall for it, and that's not fair for society. Oh, you mean to say, okay, get rid of them from the gene pool? Okay. So this is a very interesting conversation. That's exactly where the world of pathology, that's where the world of biomedical science, that's where you folks are coming in. Everything you're asking question is a very valid question, and everything the answer I'm telling you is a wrong answer. Because what I'm saying you, I'm telling you an answer which I believe in, which you don't have to believe in, and that's why you got to prove me wrong. I'm believing what the current science tells me to believe. It is your job to defy that, change that dogma. Because I'll tell you honestly, if I say anything close to what you folks are saying, I'll lose my medical license and lose my ability to earn money in America. They'll think I'm a cuckoo doctor. So I have to do what the current body of evidence keeps telling me to say, like it is not appropriate, this is not right way to do, it's not evidence based. You know, colon cancer, just because your family member has a colon cancer does not mean that every 2 weeks you get a colonoscopy. It may be a personal decision, you can do it. You may even enjoy it, some people, okay? But if you are a public figure, do not go and advertise saying that is the recommended protocol. That's what I'm trying to say. Because you don't have the right to alter other people's behavior in a non-scientific manner.
Just a quick comment, basically, the matters that obviously very personally related, but in terms of that question, basically, your body already, your blood flow, whatever, has a number of transformed cells, as you heard, not necessarily cancer cells. And the fact that some of them can go and develop into cancer cells, that's definitely a deterministic process. So the fact that you don't have the knowledge and the capability to prevent them from going there, that's different from, so basically, going back to this point, it's definitely beneficial if you have the mental capacity to take it, to know what are the possible pathways that your body can those cells, those transform cells to become cancerous, and definitely, I don't know, at some point in the future, 50, 100, 200 years, when we know the molecular mechanisms, and not right now, because like in biology, there's this big area of that we just don't know. We just do things like trial and error. But once we know them deterministically, these are just molecules, the nitrogen, carbon, and we can mechanically prevent those cells from developing into cancer cells.
Correct. Okay, absolutely correct. What Rekha is saying is absolutely correct. All I can tell you is medicine
works on a supposition right now is do no harm first. That's the oath that every doctor has taken. I want to make sure that whatever decision you make based upon my recommendations is something that you don't do, I don't do harm to you first. And that decision changes, you know, as we get more and more information, as he pointed out, as you get more and more information. When I realize that the information I have will do you more good than harm, then I will stand here, change my opinion, and tell you, Rekha, that is correct. Get your blood test every 2 weeks, because the probability is you're going to develop a breast cancer in the next 3 years is 90%. So the recommendations have changed, the science has changed. But right now, to go and tell the people that because my colleagues or my family relatives have BRCA1 or 2, I'm going to get a double mastectomy, that is not appropriate. That's not the science right now that supports it. The science does not support a colonoscopy for everybody at the age of 21. Even though we do know that there are a significant number, if you add absolute numbers in the world, of individuals who would get a colon cancer when they are 22. But the recommendation is not there. It's a population management. Right? We have to do it based upon statistics. But if there is a way to tell that this 22-year-old will get a colon cancer, and I can know at the age of 13 that within the next 10 years he's going to get a 100% chance of getting a colon cancer, I don't mind getting this person colonoscopy every 2 months, 3 months. That's a great recommendation. We don't have, the science doesn't back it up. So that's why you are here, to improve the science, to fill the gaps, to get this early warning, and then let us know what do we need to do for our patients to improve pathology. I hope you are understanding. This is why you are sitting here. That's why you're asking me questions. That's why I'm giving you unanswered questions that I have. And all I'm supposed to tell you is what I know today in medicine. I hope I will come 10 years from now and say what I said today was completely wrong, you know. Any other questions? Yes.
I just had a quick question about the personalized medicine.
Personalized medicine. That's exactly what we've been talking about right now.
So that's what I was saying. Do you think there's a big difference between the genetic mapping versus like pre and post? Like I watched a couple of talks where they're doing on the tumor section, and they're doing a huge trial of 10,000. They're showing a number that they only had like 8% of the tumors that they analyzed had any of the gene mapping that they previously associated with that type of cancer.
Right.
So do you think it's just like a limit of like the database, or is it just like?
It's just a limit of the database. We just don't know how to data mine right now. The information is out there. You know, we have zillions and zillions of data of information. Dr. Popescu has, from one glass slide on a prostate cancer, what, 2 gigabytes of information? Physical, you know, refractive index information? Half a terabyte from one glass slide. I can assure you that if you splice and dice a certain type of information from that slide using supercomputers, one can tell that prostate cancer he's just scanned will be, what is the probability of metastasis, how aggressive it's going to be, what kind of treatment can be given, what kind of treatment cannot be given, just based upon that data of half a terabyte. We just have to data mine it. It's all there. It's all, the processing, the power has to increase, and you have to ask the right questions, you know. That's why you should go and get a master's in biology too, so you can put engineering and biology together. What else? Okay, I'll quickly go through, you know, a little bit of slides I have, just to give you a perspective. By the way, we the pathologist are a guardian of a lot of tissues. In United States, if a tissue is taken out of a specimen, almost always, very rare exceptions, almost always, the tissue specimen has to come to the laboratory for an examination by a pathologist. The guidelines say that the wet tissue, the dead tissue actually in formalin, has to be saved for at least 14 days. Some people keep it for, some labs keep it for more than 30 days. Some people just keep it 14 days. The blocks, the tissue blocks that are embedded in paraffin are saved up according to the law for 7 years. 7 years. So if you got a tissue biopsy, by law, the laboratory has to keep the tissue for 7 years. The glass slides, not the block of tissue, from the glass slides from which this, from the block from which the slide is made, the glass slide is to be saved up for 10 years. Those are current laws. So if you know somebody who has had a colon cancer 4 years ago and have passed away, and you want to do research on that material, the pathology lab would have it for another 6 years, the slides. If you want the block, it will be there for another 3 years. So we do about 16,000 surgicals every year. In the hospital here across the lab, we will have 160,000 cases worth of slides, and we will have about 6 slides per case, so we will have about 1 million slides. That's stored right now. And that can be archived, that if you have an IRB, you can actually go and get those slides out and do research. There's a tremendous amount of blocks. There's a tissue banking is coming up, it's big. There are so many private companies that are actually storing all the different types of tumors for exactly the same purpose that you're talking about, same purpose you're talking about, to freeze it. So these are not paraffin embedded or paraffin fixed, they are actually snap frozen fresh. So the entire mRNA is still stuck there into a suspended animation at minus 70 degrees centigrade, and it's there. So all the pharmaceutical industry is actually collaborating with all these tissue banks to get the relevant data, right? So I'll just talk about very quickly about some red cell disorders. Basically, red blood cell is part of your blood. There are 3 cells that occur in your blood. One is called the red blood cell, the white cells, and platelets. And my intention is not to give you a lecture on red blood cells. My intention is for you to understand that you can come to a pathologist or a lab and try to access cells like red cells, where you can get interested in trying to understand what red cells are, how they behave, or you can even come and ask for tumor tissues. You can get paraffin sections cut. You can do mechanical analysis on it, chemical analysis on it, molecular analysis on it. You can process all the information using your computers, supercomputers, and then come up with some relevant data points that can be used in medicine. That's what I hope you folks will do. So there's anemia is basically a lack of red cells, in the body, which causes a variety of symptoms. So when somebody has lack of red cells in the body, they come to a doctor basically because of few symptoms, and we, the pathologist, will look at why this anemia occurred. Okay, and most of the times what we do is we measure the size of the red cells, the amount of hemoglobin in the red cells, the shapes, the size, the membrane quality, not exactly the membrane quality, the way the membrane appears around the red cells, all that. So you can have cells that are small, they are called microcytosis. There are cells that are large, you could call them macrocytosis. Some are like crenated, means they are kind of crumpled up. Some of them are kind of round and nice, they are called obviously round red cells. So we know now through association that certain diseases have certain type of red cells. So if you see certain red cells on a peripheral smear, then based upon that morphology and based upon some of the quantitative numbers, when you do a Beckman flow counter analysis, we should be able to tell, okay, these are the reasons why the patient has anemia, right? So that's the whole point. I'll show you more pictures. So that will give you, so this is a normal red cells. What you see here is basically all these cells, what you see here. This is a red cell, this is a red cell, this is a nice red cell here. So they are about 8 microns in size, and they have a little central pallor, as they call it. And what do you think? What is this one and what is this one? See a cell that is a little different? Or is it junk? What is that? Somebody said neutrophils. Neutrophils, say if you think about a red cell, which is a size of about 8 microns, neutrophils is about 10 microns. So these are much smaller than platelets, right? These are platelets. So this is exactly, we can do molecular analysis on platelets and say if you have a bleeding disorder or you don't have or a clotting disorder, right? So these are spherocytes. Spherocytes are cells that are completely dark and they are round like this. This is a spherocyte, this is a spherocyte, this is a spherocyte. Then we have something called elliptocytes or ovalocytes. These are all red cells that have taken a weird shape because of some unknown, some known diseases that we know of. This is an elliptocyte where the red cells are elliptical, right? So schistocytes. Schistocytes are when the cells get fragmented. So you can see here, this is a nice round cell here maybe. This is a nice normal one here. And what you see when the cell breaks up, it becomes like half moon here. There's a cell here. You see the cell here? you know what you call that cell? We call it a Napoleon's cap because that's what it looks like. So pathologists, when they get bored, they kind of come up with all this, different. So here is a cell that's completely kind of shriveled up here. So you can see cystocytes takes multiple shapes and forms. Echinocytes are some cells that have multiple spikes around them. So imagine if you were to take some red cells and understood the biophysical property of the membranes and see why the cells was doing this and kind of correlate with the disease the patient has. That's the information we would like to know because we don't have that information. Okay. So I want to go and kind of go a little bit more about tissue pathology and then answer some more questions. So one of the other things you can do also is, and this can occur to any part of tissue in the body, right? Infections. You can study infections. Malaria is one of the type of infection that infects red cells, and there are different shapes of red cells that occur when a malarial parasite infects a red cell. The red cell changes its shape. You can tell based upon certain physical characteristic whether it's going to be a bad malaria or a good malaria. We don't have that information right now. All I know is it's a malaria, this is the type of malaria it is. Historically I know that this malaria needs to be treated with this this anti-malarial medication, and you got to watch out for this kind of complications. So especially malarial falciparum malaria is notorious to cause brain symptoms, but some patients do get it, some patients don't get brain symptoms. It will really be nice, as you pointed out, if you do some kind of analysis based upon one's biology, am I going to get brain symptoms or not, right? That will be nice. So so one of the disorders we talk about is thalassemia. So somebody who has, the slides are not, they are kind of pale, but some of the times when the hemoglobin and globulin protein, which is actually a genetic disorder, the proteins don't get formed right, you get a disorder called thalassemia, which is very common in Middle Eastern countries. And it's common in India too, which causes a variety of symptoms, like for example, you see this individual with kind of golden brown hair. That's actually because of there isn't any much protein. It's a sign of malnutrition. And if you look at what happens here, if you do an X-ray of the head, so what do you think? Do you see all the spikes, little fuzzy kind of thing? That's not normal. Usually it is completely nice, round, even surface, very nice, round, but it's very fuzzy, and this is actually called a crew cut appearance on X-ray because somebody has got a crew cut, so that's abnormal. So you can understand that, using your, this is an example of a bone, this is an example of your bone marrow where you can see red cells. These are red cells. This is a red cell, this is a red cell, this is a red cell. This is actually a most likely it's a red cell blast. So there are red cells that are being formed here at various stages of its proliferation, which can obviously go wrong if patient has some sort of pathology. If patient has too much hemolysis, if patient has too much hemolysis, then it causes formation of gallstones, right? Just based upon red cells going wrong, there's so many different pathologies that can occur. Some are genetic, some are molecular mediated, some are like mechanical issues. For example, here is an example of a patient with sickle cell anemia, and so what has happened is this individual can you see this finger is smaller than the rest of the finger? That's because the blood supply to this is less than the blood supply to the other area. So that's why this nail doesn't have enough nutrition for it to grow. That's why it gets shortened. So there's a variety of pathologies that one needs to keep in mind, and you just don't take care of, you don't just think of in a body with somebody with just breast cancer as somebody who has just got a breast cancer. There's so many other issues that the patient is going on. Some breast cancer patients with the same stage of disease, same size of disease, survive 10 years, whereas others survive 4 years. There is a reason for that, and we don't know why. We're trying to understand it, right? Here is so give you a little I want to talk about little tissues. So basically what happens in pathology is that a surgeon takes out a piece of tissue, it comes to the lab, and it undergoes a process called grossing in, where the tissue is looked at, observed with naked eye, described what it is, it's painted, inked, measured, and cut. And when it's cut, then we tell what kind of pathology or what kind of findings we see on a cut surface, naked eye, and then we take a little bits of pieces of tissue from relevant areas and put it into little cassettes. And then once it's made into a cassette, it goes through a processing time into a machine that takes up to 12 hours, and then the tissue bits are actually embedded in paraffin wax. They're called paraffin blocks, and then a technician takes the paraffin blocks and cuts them into 3 micron thickness, 3 microns, okay, and puts them into a glass slide. Once it puts into a glass slide, then we go through a staining process, and the staining process usually we call it H&E, hematoxylin and eosin staining, and the slides come out and they get cover slip, and then it comes to a pathologist's desk for a diagnosis. We look under the microscope, we dictate the report, and the secretary types it out. If you come for a tour, you will get to see that all of it quickly. So this is how the specimens come, in little containers. Some specimens are big, some specimens are small, and they come in little formalin. And what you see here is all cassettes. These are all cassettes. And once they are done, for example, this is a gallbladder that has come. We kind of measure it, and then we cut it up, make sure there's no cancer in it, and then we put, do you know what this is? How many have got a biology background here? Anybody with a biology background? What does this mean? Yes and no? Kind of, yeah. No biology background. They're all engineers. Huh? Huh? Okay, then you should be able to answer then. Huh? Yeah, that is a uterus. You're right. This is a nice uterus, and this beautiful looking fallopian tubes here. Can you see this? And these are ovaries. Don't they look so beautiful? Yeah. So once we section these tissues, we put it into little cassettes. That's what happens. Okay. Some of the tissue pieces are large, like that. Sometimes a little colon polyp is very small. That's like 2 millimeters, 3 millimeters tissue. And this is a situation where if a doctor wants a frozen section, then we take a piece of tissue and we freeze it. And then we freeze it instead of waiting for 12 hours of processing time, as we talked about. This takes less than 5 minutes. We take a section, cut it, like this is a section, we cut it, and then we put it on a microscope, we put it under a glass slide, we stain it, and within 20 minutes we give the surgeons a diagnosis. Usually we tell them it's cancer or no cancer. That's the kind of diagnosis. We don't tell them what type and all that answers. So once the tissue blocks are all processed, they are embedded, and this is how they all look. Okay, these are the ones that are stored for 7 years at room temperature. Okay, here is an instrument that actually cuts that paraffin blocks into 3 micron sections. This is called a microtome. Here is a technician cutting the sections. This is a block, and you can see 3 micron sections. And once these 3 micron sections come out, they lift it up and put it into a water bath, a warm water bath, where this each, you can see one section here, one section here, one section here, one section here. And then what we do is we take a glass slide, and lift up this tissue, we air dry it, and then we kind of deparaffinize. We take out all the paraffin out, which is a very easy process, and then we stain it. Okay, when we stain it, here's an example of a colon cancer, how it looks. It's a large piece of tissue, and you can see an invasive adenocarcinoma here. Stain with this is a standard stain. It's called hematoxylin and eosin, H&E, where hematoxylin stains the tissue blue based upon its pH, whereas eosin stains the tissue red based upon its acidic component, whereas hematoxylin is the basic component. So a tissue will have some basic proteins and some acidic proteins. That's why if you see, it looks kind of like mostly blue, but some of it is also red. Here's a case of like you pointed out, here if you look at the cells, they're kind of like, the cells are small and they have a lot of large nucleus, right, not much cytoplasm. So compare this to a squamous cell carcinoma. Here you can imagine a tumor cell that has so much of cytoplasm and still has the small nucleus relatively. We talked about large nucleus, small nucleus, large cytoplasm, small cytoplasm. It's all over the place. Okay, so the whole context matters, and what you see here is actually a cell that's falling apart. Maybe a mitotic figure there. So this is actually a high grade invasive squamous cell carcinoma of lung. So we also use sometimes special studies to highlight certain proteins. In this situation, this is a gastric biopsy, and we use immunohistochemical stain to stain for Helicobacter pylori organisms, the organisms that causes peptic ulcer. So you can see here all the brown stain. It's very hard to see these organisms under naked eye. But when we stain it, it makes it much easier. So we have a lot of the staining techniques now which helps us identify. So before, when we did, for example, a breast cancer, a pathologist would give them a diagnosis of cancer versus no cancer. Now the pathologist today, this was about 40 years ago, 50 years ago, where a breast mass came and the doctor will say it is carcinoma. So it means it's cancer, and that's how you get treated. Now it is it an infiltrating ductal carcinoma or is it a lobular carcinoma? If it is an infiltrating ductal carcinoma, is it grade 1, grade 2, grade 3? Then we talk about mitotic activity, nuclear pleomorphism, tubule formation. Then after having done that, we talk about how large the tumor is. We talked about whether it's lymphangiovascular invasion. Then we talk about, these are all histological diagnoses. And then top of that, we do estrogen receptor markers, progesterone receptor markers. We do HER2/neu because we have a targeted personalized chemotherapy now. We do Ki67 marker, which tells us how fast the tumor is growing. We do p53 oncoprotein on it. So now the amount of information we are supposed to tell the doctors not only information is cancer or not cancer, but we are supposed to tell how bad the cancer is, so that's prognostic markers, and then we have to tell them predictive markers, which means we have to tell the doctors, hey oncologist, this breast cancer can be treated with this medication, and this breast cancer cannot be treated with certain medication. The insurance companies will not accept a certain type of chemotherapy because sometimes chemotherapy costs $100,000 a month. They won't even approve the chemotherapy until a pathologist reports out a report saying that yes, this treatment, this cancer has this receptor for which this medication can be used. So it's very complex report, which used to be a 4 or 5 liner report 40 years ago. Now it's a 2-3 page report. Sometimes even the surgeon doesn't understand what the report is. They send it to the oncologist, and sometimes the oncologists don't know what's going on. They call me. It's like, hey, can you help me out with it? So the information is growing very, very, very fast. So you have any questions? I know I try to do a very fast. I still have about 10 minutes. Yes.
I know you mentioned some activity assays. Does that, like the way you prepare the samples, does that affect the activity?
Absolutely, absolutely, because the way
activity like what? We are not looking for. You're looking for activity. Say. Correct. Okay. So. No, we don't. We don't look it up in a traditional histology lab, but what you're saying, we do look at it in the sense that you can take a little bit of tissue and put it in a special media, and then we can send it out, especially tumors, for drug resistance. We can say, okay, this tumor is resistant to these drugs, this tumor is not resistant to these drugs. Those are activity level you're talking about. Those are drug resistant markers, as they call it. Yes, we do that, but not in my lab.
But it's a send-out test. That's also happening. Yes.
Would patient history affect how you read a slide or how you interpret it?
Yeah. For example, somebody has a brain cancer, glioma. Okay, glioma is a type of brain cancer. So the patient was diagnosed and now got treated with radiation, and then now 4 months later or 3 years later, the patient undergoes another brain biopsy and gives me the piece of tissue and tells me, is it cancer or not a cancer? Right? I should be able to tell, just looking at the microscope, whether the patient has cancer or not a cancer. But sometimes it's difficult. So that's when patient history comes in. So the patient history, I would ask the doctor is, hey, can you look at the radiology report, CT scan of brain, MRI of brain, or whatever, PET scan of brain, and see if there is a increased activity in that area where radiation was given recently. So they say, yeah, there is an increased activity. I said, okay. Then I asked them, has the mass, whatever the region is, has it growing in size? They said, yeah, it has grown from 2 centimeters to 7 centimeters now. Now, based upon these two information and looking at the slides, I can tell with more degree of confidence that the tumor has come back and it is not a reactive gliosis, as they call it, which looks like tumor when somebody gets radiation therapy. Got it? So in that situation, clinical history absolutely matters. There's so many other times we need clinical history,
Yeah.
So earlier when you mentioned that you have this repository of paraffin blocks and slides and so on, is that a public resource, or is that something where someone has to bequeath their tissues in their will or their family?
No. So when anybody,
Generally, if you come to a hospital in the United States, when you ask for a consent, generally the consent that you sign is a general consent form, which is usually accepted in the United States, I'm talking about, where the patient usually gives the right for the tissue to be used for research, educational activities, and blah blah blah, right? They actually sign off on it. So once the patient has given up the right to use that for research activities, the physicians have to make sure that every necessary patient care function has been performed before they can give out the tissue for any further research, which means that you ask me a patient who is got a breast cancer 4 years ago, and you come and tell me that you want a patient slide. Patient has given a consent that I can be used for research and education. You want a section of the slide so I can analyze this tumor. So will I give it to you? You have an IRB approval. You also you have an IRB approval, right? So you got the institutional license, you have a consent from the patient, everything is right. Then it comes to me, the request. I know the patient is alive. It's been 4 years since patient was diagnosed. I look at the tissue block. I see the tissue is only 4 millimeters. Okay, breast cancer is only 4 millimeters, size. I'm going to say, I don't care what kind of research you're going to do in the world, I'm not going to give the tissue to you anymore, because I would rather keep this tissue safe for any molecular study that you're talking about. Some research may come up 2 years from now, 3 years from now, which is happening right now. Herceptin, the HER2/neu anti-HER2/neu chemotherapeutic agent, wasn't in existence 15, 20 years ago. Mayo Clinic keeps the block forever. So imagine a patient who has 20 years ago breast cancer, it has come 20 years later. Wouldn't it be nice to go back and check HER2/neu status on that case? If it's only 4 millimeter tumor, I won't give it to you. I will use it for that. On the other hand, I have 6 blocks, all 4 centimeters tumors from this patient. I said, you know what, you can have one of them. That's perfectly okay. So yes, that's how the consent process works.
So there's checks and balances in the system.
And if there's any chance that keeping it might still help the patient in the treatment, then you don't give that to someone.
Yes, as long as it doesn't affect the future patient care.
How about the generation of IP from those tissues? Is there any compensation for the patient if their tissue is? But you can still file patents on the process or something like that.
Yeah.
Patients have gotten sued, and Supreme Court has said it's not your tissue. It occurs in nature. So there have been situations where a family was donating tissues again, to this research lab, and because this was a rare disease that ran only in this 5 or 6 families, or very few families. So this patient was giving blood samples and blood samples and blood samples, and this company spent millions of dollars investigating that and coming up with this gene that was defective and coming up with a treatment for it. And once the treatment came up and the money was flowing in, just like honey, everybody goes towards the money, right? So they filed a lawsuit against this company saying that, hey, it's my genes. I should have a copy of I should have the part of the royalties, all the profits that are being made up of my blood that I gave for last 20 years. The judge has clearly said, you gave it out to research. You did not have any expectation. If that's what you did, then it's invalid. So yes, that's the problem with HeLa cell lines. Remember HeLa cell lines? Just look it up in Google. The controversy
the HeLa cell lines caused. Yes.
Are there any statistics on what the error rates, at least national, are on diagnosing the diseases in these slides? In other words, at the time you tell the surgeon to go remove the whole tissue, well, it wasn't really necessary.
Correct.
So what's the error rate, right? So yeah, there is. I mean, so that's why you have lawyers fantastic lawyers who are ready to sue the doctor for $3 million, you know, for one mistake. So during the cases like that, they actually investigate and say, will a reasonable doctor with reasonable training would have made that diagnosis? That's how they call it standard of care. And if reasonable doctor with reasonable amount of training would have made a diagnosis of cancer, and it is a cancer, even though it was not a cancer, right? They said it's standard of care.
I think the question is more about not the legal part of it,
yeah.
But the scientific part. If I'm not mistaken, I'm curious about that. In a lab, right?
Right.
Is it only one pathologist that looks at the sample, or do you do a double check, like a second opinion on it? And what is generally the error rate about the diagnosis?
Okay. So what I want to get at later is that at what point can we say the software that we have is already performing better, or maybe not even good enough to get into clinical care?
Right. Question you ask. So the question. So first question you ask. Yes, there is a QA process. That if there is a cancer, I always make sure another pathologist looks at it, even if it's an obvious cancer. It's called quality assurance process. So we show it. Okay. In our practice, majority of practices in America, but that's not always true in rest of. In sometimes Europe, it's not. You have just one pathologist signing it out. Okay. So there is a QA process. As opposed to the error rate, unfortunately, right now the gold standard is tissue biopsy, and it is supposed to be, in my opinion, supposed to be 100%. I don't know what is the error rate of tissue diagnosis visually. You know, I don't know the number. So, but if you are able to, the way you would address your problem is, if you come up with a technology, almost you have to take 20 cases of cancer, 20 cases are not cancer, and you get 2 pathologists to say which is cancer, which is not cancer, and use the same methodology to see if you are able to replicate the result. If you are able to replicate it 100%, that means you have hit the gold standard. Right, Shamira, what was our, when we did image analysis on prostate cancer, right? What was our sensitivity and specificity?
So we had 2 set of controls there. One was that we would be as good as the consensus among the expert pathologists who were on the panel. But the second one that we used was the endpoint for the patient care.
Yeah.
So we had information based on how long they survived and how long they remained cancer-free. So based on that, it was 80% and 60%, but based on 80% sensitivity and 60% specificity. But
that's pretty high.
But the existing gold standard was at 50% sensitivity and 50% specificity. So that was a quite toss.
Shamia, what are we talking about?
Prostate cancer prognosis.
And prognosis, but based on H&E?
No, unstained tissue.
Unstained tissue on a slide?
Yeah.
50-50.
Yeah, because it was a very difficult problem to catch, and we used the hard cases.
So the answer is that's what you have to do. Controlled trials, you know, if you're able to hit.
But for you as a scholar, you say 100% matching what physicians do would be an acceptable.
Oh yes. To me, if somebody has to be told they have cancer or not a cancer, it rather be, it has to be 100%. They cannot be any room for error there, you know, because that 1%, that 0.1% matters, you know. Yes.
The gold standard is a statistic.
But having said that, for example, in pap smears, right? I won't say pap smear, in the case of melanomas. The melanomas, if you take 20 difficult cases of melanomas. Melanomas are always not easy. I'm talking about 20 difficult cases of melanomas. And they took 3 different experts, right? And these are experts in melanomas, right? And you show them the 20 cases and say which is melanoma, which is not a melanoma. The concurrence rate among this expert pathologist was not very high. On melanomas, on difficult cases of melanoma. Simple case of melanoma we all know. So, even in existing practice,
unfortunately, tissue diagnosis is the gold standard. Cannot come up with a right number as to which is, what is the error rate. Because if you look, when you have pathologists who are very high ego people, there are two of them who have done melanoma research for 30 years each, and they look at the same slide. One says it's melanoma, other says it's not melanoma. Who's right, who's wrong?
Biochemistry.
Well, we can do that, but we don't know that information yet. It may be in the future. Okay. What else? Brain biopsy possible? Okay. One more? What is going to happen? The IQ is going to go down a little bit. Depends on where you're going to take your, brain biopsy from. There are parts of the brain where you can take a bunch of this thick piece of brain and nothing happens. Whereas if you take this little pinhead of a tissue, a certain part of the brain, you get paralysis. So it depends on where the it all depends where the tumor is. If there is a tumor somewhere in the brain and it's causing symptoms, we don't care what the patient is going to have a stroke after that or some kind of, that's part of, you want to make sure the patient, you try to do overall good for the patient, right? So if the patient is growing, so for example, in the auditory part of the cortex, where you have a brain tumor growing. Say because of the brain biopsy, right? We find out it's cancer, this patient stops talking or has difficult speech, but that's a known risk and complication of the procedures. We have to do it because we want to make sure the patient lives. Patient rather live and not talk than not patient talk at all for the rest of the life, right? So that's the risk and the benefits you have to take. Yes. There are instruments that are there that take very narrow, small pieces of. Yes, they do that. Well, it's an interesting group here. So where are you folks from? I mean, like all over the world, all over the US, or all over Champagne? Or from outside the country?
I guess you have 25% of the attendance from the outside US.
Where are you from?
Boston.
Boston. That's outside the country, right? Yeah. The way you talk, yes. Huh? Boston.
Ann Arbor, Michigan.
Ann Arbor. Community college, right? Huh? Texas A&M. China. China is big. Where's China? Where in China? Okay. Pennsylvania? Same?
It's from Iran, but studying California.
Okay. You?
I'm from here.
Okay. You, Rekha? India. Where in India? India is a big country. IIC, very good. Same thing, Austin. Houston. California. Houston, Texas. And
Romania.
Romania. Okay. St. Louis.
Canada.
French speaking? What? French speaking Canada? Okay, good. St. Louis. Oregon.
Wyoming.
Wow, wild, yeah. Hong Kong, awesome. If you have any questions, I'll write the email address here. Do you want my email address?
Free consultation.
Free autopsy. Anytime you want. Free autopsy anyway. Anytime. Okay, here's my email. You want my email?
Okay, guys. So you're from around here?
Yeah, I'm from around here.
Good.
Probably on my way back.
That's my email address. Tangella@government.com. Shoot me an email, send me an invite on LinkedIn.
That's his website.
Oh.
They changed again. Okay, guys, thank you very